Hello, and welcome to a crash course on separation anxiety. My name is Jess, and I am a third-year veterinary student at the University of Pennsylvania. I wanted to make this video as a quick and accessible resource for students who are learning about this topic during their second year or students on the clinical behavior rotation. While this video doesn't have all of the information you may need, I hope it can serve as a short and concise guide to approaching patients who we suspect have separation anxiety in order to better inform us as future clinicians, especially in the behavior and small animal general practice setting, by asking good questions and creating effective treatment plans. Today, we will be going over separation anxiety in this outline. So, what is separation anxiety? Separation anxiety is stress that occurs in a person's absence or perceived absence, and this is oftentimes for our patients, their owner. Because domestic dogs usually consider the human family to be their social group, they become bonded to family members, and when they are separated from family members, dogs may experience distress and engage in problem behaviors related to the anxiety of separation. So let's talk about signalment, prevalence, and risk factors. Separation anxiety is a very common problem seen in small animal behavior and general practices. One survey suggested 14 to 17% of US households with dogs deal with separation anxiety. But what are some risk factors? In a study done at VHUP in 1991, a population of 55 dogs revealed that mixed breed dogs and strays were overrepresented in the group with separation anxiety. When mixed breed purebred dogs were compared with regard to duration of ownership, age when acquired, type of household, and origin of dog, only the origin of the dog was highly significant. It is suggested that the reason there was such a high percentage of mixed breed dogs in the separation anxiety population is due to more mixed breed dogs coming from shelters or being strays. It is suggested that previous lived experiences, many of which are unknown for these dogs, could play a role in separation anxiety. It is important to also identify genetics, epigenetics, and lived experiences, especially in the first 3 to 12 weeks of life, as factors that play in the development of separation anxiety. These factors can't always be controlled, and most of our patients come in around 1 to 4 years old when social maturity occurs, and it is important to relay this information to owners so they can better understand why this is a diagnosis of management rather than one that can be cured. In a study published in 2001 on separation anxiety, risk factors identified in dogs with separation anxiety included pets who follow the owner around the house regularly, pets with increased arousal when the owner returns home, panting and whining when the owners put on their shoes or grab their keys or put on a coat, destruction, elimination, and vocalization. Other risk factors include changes in routine, long periods of being left alone, and moving to a new environment. Also, in a study with 62 geriatric dogs done in 2005, 29% of the population had separation anxiety. It is important to screen these patients specifically for canine cognitive dysfunction, as it can have similar clinical signs in aging patients. So now let's talk about clinical signs. And remember that all of these should be considered within the context of the dog being left alone or perceiving they are being left alone. For dogs, this can include, but is not limited to, vocalization, destructive behavior, loss of appetite, depression, decreased activity, excessive greeting behavior when the owner returns, inappropriate elimination, vomiting, diarrhea, hypersalivation, panting, and excessive grooming. Cats may show more subtle signs, but these signs may include inappropriate elimination, vomiting, excessive vocalization, excessive grooming, loss of appetite, and destruction. So now going into diagnosing separation anxiety and asking good questions. A lot of our diagnosis is going to come from asking good questions to build a picture of the behavior the owner is experiencing and to rule out or rule in other behavioral issues the patient could have. Some good questions may include, how does the patient react when you begin to show signs of leaving the house? What are some specific triggers the patient has that alerts them to think you are leaving? What sort of behaviors does the patient exhibit when left alone at home? Where does the patient go in the house when they are left alone? Is this behavior exhibited in other contexts besides you not being home, such as hearing loud noises, being put in the crate, or when people enter the home? And what is the patient's behavior like when you return home? Asking good questions, especially one specific to the patient, can help identify triggers and inform a better treatment plan. Sometimes asking the owner to provide visual aids such as videos can help better paint the picture of the behavior. You can ask for videos or suggest they try capturing the behavior on a camera. Remember to also always rule out underlying medical causes for behavioral issues. Taking a good physical exam and getting blood work when possible can help shape if pain or discomfort is a factor in the patient's behavior. This table was made in a paper published in 2008 on separation anxiety to help rule in and rule out medical issues that can also be expressed in behavior patients. It is important to differentiate separation anxiety from other similar and related diagnoses. But remember, a patient can have a combination of these behaviors and diagnoses, so make sure to identify different triggers and behaviors for each context. First, let's talk about hyperattachment. This is what we describe as the Velcro dog, where the patient follows the owner around the house normally at most or all times. Then there's confinement anxiety. This is when a dog becomes anxious when it is confined within a space, such as a crate or a room, even if the owner is home and near it. Next is noise fear or phobia. This includes fearful behaviors towards specific noises. Commonly in our patients, these can be fireworks, thunderstorms, yelling, and many others. Then there's environmental fear. This is fearful or phobic behaviors of stimuli associated with specific environments, such as the trash trucks or city sounds and smells. And it is especially important to ask about this for our patients living in urban settings like Philadelphia. Lastly, generalized anxiety disorder. Many of these patients may have generalized anxiety disorder, and that is why it is important to understand its definition. Remember, separation anxiety is stress and behaviors that occur in the absence or perceived absence of the owner. However, generalized anxiety disorder is when a patient is anxious in many situations or environments. These patients fear a lack of predictability and changes in their routine. Anxious behaviors may occur in the absence or anticipation of a trigger, or the behavioral responses may be extreme even with minor incidents. These pets are in a state of prolonged anxiety and they have trouble habituating to situations, not just being separated from their owner. Now for treatment. There are three important parts to treating any patient with a behavior diagnosis. This includes behavior modifications, environmental modifications, and medical management. It is important to always inform owners that medication alone does not cure behavior problems, and much of the improvement relies on behavioral and environmental modifications. For environmental modifications, avoidance of triggers is important in order to mitigate undesirable behaviors that occur upon the owner's absence. Avoid leaving the pet home alone by considering babysitters, daycares, or friends and family that can help watch the pet. Creating a safe haven is also a big part of management. Having the owners create a space where they can teach their animal to have positive associations, such as treats, and understand that it is a safe place during times of high arousal can aid in mitigating undesired behaviors. Masking outside stimuli can also serve to remove triggers associated with high arousal. Suggesting things like window covers, white noise, music, audiobooks, and other things can help mask outside stimuli that occur when the owner is not home or sounds associated with the owner's departure and arrival. And lastly, pheromones. There are dog appeasing pheromones out there that can be put near the safe haven to further help alleviate some of the stress the patient feels when left alone. Now for behavioral modifications. Relaxation exercises can be a useful aid to practice on a mat or in the pet's safe haven in order to create a positive association with that space in times of stress. Avoid punishment, as it is important because many of these patients have a higher than normal baseline anxiety and cannot always control this undesired behavior. We don't want these patients associating a negative action, such as yelling or pain, with an already stressful stimuli, as this can lead to even more undesired behavior. Next, uncoupling departure cues. Telling the owner to practice tossing treats when they pick up their keys or when they put on their shoes can help counter condition and desensitize the patient and create positive associations around these triggers when practiced every day, even without a departure. Also, exercise prior to departure can help the patient exert some of the energy it may have prior to departure and decrease arousal state. Next, shortening the departure routine and limiting short returns to the house are also important. Providing toys, food puzzles, and scent work can again foster positive associations around the separation and redirect the patient to focus on something that is more rewarding. Lastly, redirection cues when coming home, such as touch, find it, look, or going on a walk, can help interrupt the excessive arousal when the owner returns home. Lastly, medical management. Medical management can be used in many of these patients with higher than normal baseline anxiety levels to aid in their ability to make positive associations and learn coping strategies. When the patient is in a state of high arousal, their amygdala, where the limbic system lives as the emotional control center of the brain, is activated. Many of these patients have a lower than normal arousal threshold, and when the limbic system is too highly aroused, it cannot communicate with the prefrontal cortex, which is the part of the brain where learning and memory takes place. Medication can help dampen the limbic system so that learning, behavioral modifications, and making positive associations can occur. The FDA-approved drugs for separation anxiety include Reconcile, whose generic form is fluoxetine, which is a selective serotonin reuptake inhibitor, and Clomicalm, whose generic form is clomipramine, which is a tricyclic antidepressant. Reconcile and Clomicalm are veterinary formulations of these generic drugs and have been found to have higher bioavailability in our veterinary patients. Additionally, bridging and situational or fast-acting medications such as gabapentin, clonidine, trazodone, and benzodiazepines can be used. It is important to always educate owners on drug types, potential side effects, and their expected effect time. Many owners come in hoping the drugs will take immediate effect, and certain drugs such as SSRIs and TCAs can take weeks to see effects. Additionally, most of these medications are eliminated by the liver and/or kidneys, so it is important that our patients have annual blood work done to ensure these organs are functioning properly. In the last slide of this PowerPoint, I included a drug chart on all of the drugs listed above for students looking for a quick reference. Remember, medication is not the end-all be-all for patients with separation anxiety, and much of the treatment protocol relies on behavior and environmental modifications to see improvement. I hope this helped, and good luck.